Hello, everyone, and welcome to today's Health for the World Grant Runs. A big thank you to Dr. Bavia Rehani, President of the Health for the World Academy, for inviting me and giving us the chance to learn from some of the top radiologists in the field. And thanks as well to Bavia Vunava for her great support and organizing today's Zoom session. This grant round will be recorded and uploaded to the Health for the World Academy's YouTube channel and website. Feel free to visit and subscribe to the YouTube channel to explore other lectures that might interest you. Please type your name and country in the chat box and feel free to submit your questions in the Q&A box. It's my pleasure to introduce our distinguished speaker, Dr. Ali Nabavizadeh. He is an associate professor at the University of Pennsylvania and serves as the program director for the alternate fellowship pathway. He is also the director of the Translational Imaging Research Unit at the Children's Hospital of Philadelphia's 3DB Center. Dr. Nabavizadeh is a prolific researcher and a renowned expert in radiology, with a research focus on utilizing imaging and liquid biopsy biomarkers to enhance tumor response evaluation and prognostication. His work has been recognized with multiple awards, and he holds editorial positions and reviews for several high-impact radiology and neuro-oncology journals. Today, Dr. Nabavizadeh will be presenting on decoding tumor response, conventional and molecular imaging in neuro-oncology. Please join me welcoming Dr. Nabavizadeh and exploring the latest advancement in molecular imaging and neuro-oncology.
Thank you very much, Dr. Savic, for the nice introduction. And I want to thank the organizers for inviting me. I really want to acknowledge what tremendous platform this is for trainees. And so I'm gonna talk about decoding tumor response, conventional molecular imaging in neuro-oncology. I'm a neuroradiologist and also a nuclear medicine radiologist at University of Pennsylvania, and I also have a research affiliation with the Children's Hospital of Philadelphia. These are my disclosures. I'm going to be talking a little bit about RANO and RANO 2.0, RAPNO for pediatric brain tumors, and also at the end, I'm going to talk about PET RANO, PET response assessment based in neuro-oncology, and a few slides about meningioma and some of the kind of future directions. So why do we need response assessment in neuro-oncology? That's the basic question. So we know that brain tumors, both primary brain tumors and secondary brain tumor metastatic lesions, they require a nuanced assessment to be able to guide therapy and evaluate benefit of any treatment. And even though overall survival is a definitive endpoint, but it has significant limitations. First of all, it's a delayed endpoint, and also it's confounded by post-progression therapies. So it's not practical for early phase or adaptive trial designs. And that's why we need early surrogate endpoints, such as objective response rate, which measures the tumor shrinkage after treatment, and also the progression-free survival, which is a clinical radiographic endpoint that captures tumor progression on imaging. And so more and more regulatory agencies, both in US and Europe, they're accepting these surrogate endpoints for accelerated approvals. And to complicate that, novel therapies such as immunotherapies and anti-angiogenic therapies and molecular targeted therapies frequently complicate traditional imaging interpretation. So we need more and more advanced response criteria in neuro-oncology. And so historically, neuro-oncologists try to adopt McDonald and RECIST criteria from the body. However, they had significant limitations because they didn't take into account non-enhancing tumor progression and also pseudoprogression and pseudo-response. And so RANO criteria was introduced in 2010 to reflect unique disease biology in the CNS tumors, and to be able to evaluate endpoints such as objective response rates and progression-free survival, and also to guide eligibility for trials and whether to continue treatment or not, and confirmation of response to treatment. And so MR is the workhorse for neuro-oncologic imaging. We use MR for structural imaging, contrast-enhanced MR to evaluate vessels. MR can help us to see hemorrhage and vessel integrity, diffusion MR for cellularity, and also perfusion MR for tumor perfusion. And also MR can give us some idea about tumor metabolism. And obviously we use MR for pre-surgical mapping. And the RANO criteria are based on MRI. They were introduced in 2010 with the RANO high-grade glioma, followed by RANO LGG in 2011, iRANO in 2015 to account for pseudoprogression that happens specifically after immunotherapy, and also RANO brain mets in 2015, modified RANO criteria in 2017, and finally, in 2023, the RANO 2.0 simplified the prior versions of RANO for glioma, and also after WHO 2021 that came out that the margin between a high-grade and low-grade glioma was blurred, and there was a lot more emphasis on molecular characteristics. So RANO 2.0 focused to have one response assessment criteria both for high-grade and low-grade tumors. And these are two papers about RANO 2.0. You can see at the top, this is the original RANO 2.0 paper that was published in Journal of Clinical Oncology. And you can see a neuroradiologist guide that was published in HANR in 2024 that I was also part of the co-authorship team. And this work was led by Ben Ellingson and Francesco Sanvito from UCLA. And it's a very helpful kind of review about how to operationalize the RANO 2.0 criteria that I'm going to show some of the key highlights of this paper as we move along this talk. So as I mentioned, RANO 2.0 uses a unified set criteria for both high and low-grade glioma in adults. And it also incorporates concepts that was previously part of the modified RANO criteria, including adopting post-radiotherapy scan as the baseline. And also it mandates a confirmation scan to distinguish progression from pseudoprogression if you're within 12 weeks of completion of radiation. And also it allows for adoption of a volumetric tumor measurement that was also part of RANO, a modified RANO criteria. So it's very important to have a standardized brain tumor imaging protocol. This is the protocol recommended by RANO 2.0. And you can see the parameters. It's strongly encouraged to have 3D volumetric T1 pre and post contrast to allow for multi-planar reconstruction and volumetric measurements if needed. DSC perfusion imaging is encouraged, but is not formally part of the RANO criteria yet. So baseline scan, this is key, and also one of the differences of RANO 2.0 and modified RANO compared to prior RANO versions. So in newly diagnosed glioblastoma, the baseline scan was the first post-radiation scan. So post-surgical and pre-radiation scans should not be evaluated as baseline in RANO reads. For recurrent glioma, a pre-treatment scan is used as a baseline. Ideally, it should be within 14 days before starting any new treatment. And even if we can have a hyperacute scan, that would be better, like a scan within 1 to 2 days of starting a new treatment. Because these tumors, remember, these are fast growing. And so if the scan time, the interval between the scan time and the starting of treatment is more than a few weeks, the tumor can continue to grow. And so the first scan can, after treatment, could falsely lead us to think that the tumor is progressing because we didn't image the tumor close enough to the treatment period. So the pre-treatment scan should be as close as possible to the new treatment in recurrent glioma. In terms of tumor components to evaluate, per RANO 2.0, we need to evaluate both contrast enhancing and non-contrast enhancing, or both, depending on the tumor type. If the tumor type is enhancing, that needs to be evaluated in all tumors. Non-contrast enhancing tumor need to be evaluated in predominantly non-contrast enhancing tumors, and also mixed tumors that have both components. If we have a trial that includes vascular permeability anti-angiogenic agents such as bevacizumab, we also need to evaluate non-contrast enhancing tumor. In terms of measurement technique, we use bidirectional measurements or 2D measurements, and if there are multiple lesions, we use the sum product of two perpendicular diameter of multiple target lesions. I'll tell you what target lesion is in a minute. Volumetric measurements, it could be manual or semi-automatic or automatic, depending on what's available. And within a given trial, if we choose 2D or 3D, we have to continue with that. And for 2D, the target lesions need to be measured in a plane that has the largest area of the lesion. So for measurable disease, one or more lesions with clear margins should be included. If you have 3D imaging available, the lesion should be more than 10 millimeter in all planes. If you have 2D imaging available, the lesion should be more than 10 millimeter in the plane that is imaged, and also should be visible in 2 consecutive slices. And this applies to both contrast enhancing and non-contrast enhancing disease. So non-measurable disease are all the other lesions that do not meet the criteria for measurable disease. It's important to kind of keep in mind that in cystic or necrotic portions of the tumor or the resection cavity, we're not going to measure that or include that in the measurement. And if you have rim enhancement surrounding the resection cavity or a cyst, which is very common in both pre-treatment and especially post-treatment glioblastoma, that would be considered non-measurable disease. So target lesions basically are the measurable lesions that are chosen for longitudinal quantification of tumor burden. So if we have one dominant lesion, that would be our target lesion. If you have multiple nodules, we are allowed to include up to 3 nodules to measure and monitor. And we combine the size of the nodule by just adding the 2D sum product of these lesions. It's preferable to include the larger or enlarging lesions if you have multiple measurable lesions. So this is a schematic diagram from the HANR paper that shows that different scenarios. If you have a contrast-enhancing tumor, then the non-enhancing tumor would not be considered as target lesion. Enhancing lesion, if it's more than 10 millimeter in all 3 planes, that would be our target lesion. Up to 3 of them can be included. For non-contrast enhancing tumor, again, same criteria. If they're more than 10 millimeter on 3 planes, up to 3 would be our target lesions. And for mixed tumors, the same kind of workflow will be applied both to enhancing and non-enhancing part of the tumor. The target lesions that are more than 10 millimeter would be measured and monitored. So non-target lesions, they're not monitored, but qualitatively they'll be recorded, and if they grow and become measurable, then they could be included in the target lesion measurements. So for 2D measurement, you need to draw 2 perpendicular diameter on a plane or slice that the lesion is the largest. And if you have 2D imaging, we need to confirm imaging that it is seen on 2 consecutive slices. Again, we need to avoid including surgical cavities, cystic areas, and necrotic areas or meningeal thickening. And because we're measuring multiple time points, we need to be consistent. Few examples. So if you have 3D imaging, we confirm that the size of the lesion is at least 10 millimeter in all three planes. If you have 2D imaging, we choose to measure the lesion in the slice that is the largest. However, we'll confirm on a slice above or below that the lesion can be seen on two slices. Example of a non-enhancing lesion and has measurable lesion. So some pitfalls, again, this is incorrect. If you have a surgical cavity and an enhancing nodule adjacent to it, we don't measure the whole thing. We only focus on the enhancing nodule, and the measurement should be focused on entirely within the lesion, not outside the lesion, to include normal brain for maximum accuracy, and also focus on part of the lesion that is minimally contaminated by adjacent structures, whether that's surgical cavity or normal brain. For non-contrast enhancing tumor, focus on a part of the tumor that has well-defined margins, like this one, compared to this one, which kind of tumors has poorly enhancing margin, kind of blurs with normal brain. And if it's a mixed tumor, we need to measure both components, the non-enhancing component and the enhancing component as target lesions. Again, if you have one measurable lesion, that's easy, 2 perpendicular diameters. If you have multiple, we just measure every one and add them together. The 3D measurement considerations, if we have access to 3D volume segmentation through either a semi-automated or automated platform, that's great because it allows a more comprehensive measurements of all tumor burden compared to just focusing on a few lesions. If you want to do 3D imaging, we need to confirm presence of a measurable disease using 2D criteria first, and I'll tell you what that means in a second. So this patient has multiple nodules, and you can see this dominant nodule here and one medially. And first of all, we need to confirm that this nodule is more than 10 millimeter in all three planes. So this is confirmed. And after that, then we can use 3D segmentation that gives us the tumor burden. And tumor segmentation, it just focuses on all the enhancing part, even what is surrounding the section cavity. You can see examples of 3D segmentation that on non-measurable disease. So you can see that using the 2D criteria, this lesion is less than 1 centimeter in all 3 dimensions. And so this is a non-measurable disease. And so in terms of RANO 2.0 response categories, we have 5 response categories: a complete response, when we have disappearance of all the target and non-target lesions. Yeah, partial response if you have at least 50% decrease on 2D and 65% decrease on 3D. And also minor response, which is only applies to non-contrast enhancing disease, and that has 25 to 50% decrease on 2D, 40 to 65 on 3D. And progressive disease, which we have 25% increase on 2D, 40% increase on 3D, noting that this need to be confirmed with a follow-up scan after 4 weeks if you are within the 12 weeks after radiation. Other considerations with regard to steroid, leptomeningeal disease also are very important. I'll discuss later in the talk. And a stable disease is when all of the scenarios do not meet any of these response criteria. And so this is a schematic from the AJNR paper. It's a little bit busy, but actually it's very helpful that we take you through all the scenarios that could happen when you have a newly diagnosed patient or a recurrent patient with glioma. And if you have measurable disease, then depending on whether you see increase in size of the lesion, then if you are within 12 weeks after radiation, then that would be a preliminary progression, and you need to continue imaging after 4 weeks, which if it continues to grow, then that would be a confirmed progression backdated to the initial date. Or if it doesn't continue to grow, then you will call it a confirmed pseudoprogression. And same applies for stable disease, which is easier. No significant increase or decrease in size, or if you have a response, meaning that shrinkage in tumor, that needs to be confirmed after 4 weeks to make sure it's persistent. So again, this schematic is very helpful, but I'm going to take you through some cases just to make it easier. So this is a patient with a GBM that had started with non-measurable disease. And after about 16.8 months, that nodule significantly grew. So we are not within the limits of 12 weeks, so we don't need any follow-up scan. We can call progression right here. And you can see that's the point, and that's the follow-up study. When the patient was off a study, the lesion continued to grow. Second example of a patient who was actually within the 12 weeks period. This is the baseline, this is the follow-up at day 56. You can see that the lesion size significantly increased on follow-up. However, because we are within 12 weeks of completion of radiation, we need to confirm the progression by a follow-up scan, which showed continued growth. So the progression is confirmed and the date of progression is backdated to the scan that initially showed progression. And finally, this is the case of pseudoprogression, that this is the baseline scan, a follow-up scan within 3 months of radiation showed growth. So this is preliminary progression, but requires confirmation, which actually didn't show continued growth. The volume actually decreased and the 2D dimension decreased. So 6% decrease compared to the second scan. So this is a confirmed pseudoprogression. So even though we call it preliminary progressive disease, but because the follow-up scan did not confirm continued progression, this is a case of pseudoprogression. Leptomeningeal disease, it's very important. Appearance of any new or clear leptomeningeal involvement is sufficient to determine progressive disease, but it's important to only call on equivocal and extensive leptomeningeal disease as such. Sometimes we see mild enhancement along one caudal nerve root. That is not confirmation of leptomeningeal disease. If we see like multiple nodular enhancement or like diffuse leptomeningeal enhancement in the brain and the spine, coating the spine or in the IACs or the places that we usually see leptomeningeal disease, that would be definitive for leptomeningeal disease and for progression. Clinical deterioration is very important. And it is sufficient to define a progressive disease. It's important that we also take a look at the steroid dose. If the clinical deterioration happens at the time that we decrease the steroid dose, that wouldn't be sufficient to diagnose pseudoprogression. And it doesn't require confirmation scan and can be defined by a variety of criteria, including KPSD, COG, NANO, or simply better, stable, or worse, how the patient is doing. Steroid use is also very important because it can alter contrast enhancement and edema. So if you have any response, whether that's complete, partial response, or minor response on a steroid dose that is increased, then the response is downgraded to stable disease. And to qualify for complete response, patient must be off steroid or just a physiological replacement dose of steroid. And if we have progressive disease but the steroid dose recently decreased, then the response should be changed to stable disease. So it's really important to work with the clinician to know what happened to steroid dose and whether that is still is something that patient is receiving or has there been any change in steroid. So again, to summarize, these are main features of RANO 2.0. Baseline MR is different for newly diagnosed. The post-radiation scan is baseline for recurrent tumor. A scan very close to recent to the new treatment. The tumor component measurement is different for contrast enhancing versus non-contrast enhancing tumors. We can do it 2D or 3D, and these are the thresholds for tumor response. And it's very important that we would need confirmatory scans if we are within 12 weeks of radiation. And also for any response, we need a confirmatory scan to make sure that the response is durable. Okay, let's change gears here and talk about the pediatric. So response assessment in pediatric neuro-oncology, this is something that started in 2011, inspired by the work in adult RANO working group. And it aimed to define objective standardized assessment for pediatric population and address unique challenges that are present in pediatric brain tumors. And you might ask, why do we need a new criteria for pediatric brain tumors? The reason is that pediatric brain tumors are in many ways unique. You can see these are publications of the RAPNO working group, that the initial publication focused on the challenges, followed by 6 publications on tumor-specific guidelines, medullo, cranial, DIPG, high-grade, ependymoma, and low-grade. And this is a review that we published in Neuro-oncology and outlined 8 challenges in pediatric brain tumors, noting that some of these challenges are not unique to pediatric, but some of them actually are, or at least for the most part. I'll just focus some of the challenges: differentiation of non-enhancing solid tumors from peritumoral edema. That I would call it a common challenge between pediatric and adult. However, cystic components and differentiation of non-enhancing tumor from cystic component, that is actually much more challenging in pediatric, because cystic components are much more common in pediatric brain tumors. Differentiation of various cystic components. Determining contrast enhancing tumor, that is very problematic in pediatric, because many pediatric tumors are non-enhancing, and even some high-grade pediatric tumors are non-enhancing or only mildly enhancing. Leptomeningeal spread, that is much more common in pediatric brain tumors compared to adult glioblastomas, which less commonly show leptomeningeal spread. Intraorbital and supracellular tumor extension, that's also much more common in pediatric brain tumors. And we also outlined some of the challenges of automated segmentation in pediatric brain tumors. I'll give you a few examples. This is outlines the challenge of the non-enhancing solid tumors from peritumoral edema. You can see the labels here, that this is peritumoral edema in purple and non-enhancing tumor in green. Compare mildly enhancing tumor challenge. You can see a tumor that's very mildly enhancing. Chemo subtraction can help. It's another example. This patient has high contrast enhancing tumor, so this is not a challenging case. Identification of cyst and differentiation of non-enhancing tumor from cystic components. You can see that on T2, the cyst and the solid tumor components, they almost look the same. Looking at other sequences such as FLAIR and T1 post would help us. Also, this outlined the challenge of intraorbital and supracellular extension of tumors. So based on the RAPNO guidelines, there's some significant similarity to RANO guidelines. Again, measurable lesions should be 10 millimeter with clear margins, and non-measurable lesions are the ones that are smaller. Target lesions, that are measurable lesions that are selected for longitudinal follow-up, and there are different numbers that we follow based on the different tumors. For ependymoma, it's 3, and also the IPG and high-grade glioma, up to 4 lesions in medullo and up to 5 lesions in low-grade glioma. And non-target lesions are the measurable lesions that basically they wouldn't be selected as targets. Imaging techniques, again, similar to RANO 2.0, it's very important to have a standardized imaging techniques for pediatric brain tumors. The recommended guidelines are published on RAPNO publications for both brain and spine MRI. So I'm not going to focus on everyone, but I'm going to focus on the main points. Gadolinium is important and required at baseline and follow-up imaging. In rare cases, such as non-enhancing pediatric low-grade gliomas, or craniopharyngiomas. We can have scans that are non-enhancing. And these are imaging recommendations for RAPNO for brain tumor imaging. You can see the protocol and also the different tumors, medullo, DIPG, LGG, HGG, ependymoma, and craniopharyngioma. This is pre-contrast, this is post-contrast. And you can see that some sequences are optional and some sequences are recommended. For example, for ependymoma and craniopharyngioma, in addition to the routine sequences, RAPNO group recommended Fiesta or cyst sequences to better assess the cysts in craniopharyngioma and also to better assess the tumor deposits in posterior fossa and ependymoma. So again, this is something that if you want to do imaging per RAPNO criteria in any of the tumors, I would recommend you to refer to the specific paper and look at the guideline, what sequences are required and recommended. These are the MR protocols for low-grade glioma and craniopharyngioma, specific protocols in addition to the routine brain imaging that requires for orbit and cellular region for these tumors. This is the RAPNO recommendation for spine imaging. Again, the protocol is different if you're interested in leptomeningeal screening, if the tumor is in the brain, or if you're dealing with a primary spinal tumor. Again, if the tumor is in the brain and you're specifically looking for leptomeningeal screening, these are the sequences that are actually required: sagittal, cyst, or Fiesta, and also or sagittal T2-based cube space or Vista sequences are required. This is a RAPNO recommendation for performing brain MRI. Again, RAPNO recommendations are more complicated than RANO 2.0 because they are tumor specific, and each tumor has its own specific recommendation. One key difference between RAPNO and RANO 2.0 is that the baseline scan, for the most part, would be considered the immediate post-op MRI if it's 72 hours performed after the operation. And if we don't have it, then they would recommend a delayed scan. But again, you can see the very specific recommendation for every tumor in this table. This is a very helpful review article that was published in Neuro-oncology that I recommend reading if you're interested in imaging pediatric brain tumors, timing of follow-up brain MRI, mentioned in every tumor, and also baseline spine MRI and timing, whether that would be needed or not based on the tumor histology. So 2D approach, that's the current standard for response assessment in RAPNO. Similar to RANO for single lesion, longest diameter and largest periappendicular diameter in the axial plane. Again, measurements should be systemically performed in the same plane over time. And if we have multiple lesions, again, the maximum lesion that we can measure, maximum target lesion, varies by the tumor, up to 3 in ependymoma, DIPG, and HGG, up to 4 in medullo, and up to 5 in LGG. 3D and volumetric, that is not standard in RAPNO. However, it is recommended if feasible, and also at least to be a supplementary 3D measurement is encouraged per RAPNO guidelines. So how do we calculate total tumor burden? We add up the sum product of the perpendicular measurements, if there are multiple lesions or just one single lesion. And there are two key considerations here for DIPG and craniopharyngioma about the cystic component. So for DIPG, the cystic component will be included in the overall tumor measurements. However, both the cystic and solid component, they require separate evaluation and different cutoffs for comparison. For DIPG, there is a separate evaluation for the pontine and extrapontine tumor component. So that is important to keep in mind. I'll show you some examples. So this is for the cystic component that is common, especially in low-grade glioma and craniopharyngioma. So for low-grade glioma, you can see at the top a cyst that is kind of really is integrated into the tumor. You can see this thick rind of tissue surrounding the tumor, and also you can see that this tissue is enhancing. So this is a tumor cyst that will be included in the tumor measurement. On the other hand, in the bottom row, you can see a cyst that shouldn't be included in the tumor measurement. It is located at the interface of the tumor and the brain. And you can see that there is no significant enhancement in the cyst wall. So this would be a cyst that wouldn't be included in the tumor measurement. So craniopharyngioma mentioned that the cystic and solid tumor components should be separate, should have separate measurements. Response criteria for different tumors according to RAPNO. Again, you can see the histologies here: medullo, DIPG, HGG, LGG, ependymoma, and craniopharyngioma. Important thing again, for DIPG, the pontine and extrapontine tumor components have different thresholds for both partial response and progressive disease. And also craniopharyngioma, the cystic component should be adjudicated differently compared to the solid components. I show you a separate slide just to make it more clear. So in low-grade glioma, the cystic growth would be treated differently compared to the solid tumor component. If the cystic component is more than 25% of the solid component, then that would be progressive disease. However, in the case that the cystic growth is stable or less than 25% growth in the solid tumor component, we need a short-term follow-up MRI in 4 to 6 weeks. And if there is substantial mass effect or symptoms referable to the growth, then the cyst need to be decompressed. And if you have continued worsening, cyst wall enhancement, and or solid tumor progression, then we'll call it progressive disease and would treat the patient accordingly. For craniopharyngioma, the radiation would be key. So if we are within 12 months of completion of radiation, any cyst growth would be considered stable disease irrespective of associated symptoms or surgery. And surgery is allowed, the cyst intervention, whether that's through fenestration or craniotomy or a catheter placement, that is allowed, but that wouldn't mean that the patient has progressed if we only see growth of the cystic component within 12 months of completion of radiation. However, after 12 months, if the patient has associated symptoms related to the cyst, or if surgery is needed to relieve the symptoms, that would be considered progressive disease. So again, radiation would be key in craniopharyngioma, considering the cyst growth and whether to call it progression or not. So again, similar to RANO 2.0, non-radiological variables are important. And that includes some treatment, functional, and lab kind of info that they have to be correlated with neuroimaging and findings for final response assessment. So RAPNO guidelines are out, but again, there are definitely room for enhancing RAPNO guidelines. This is a letter to editor that we recently published in Neuro-radiology, focusing on how to enhance RAPNO guidelines. Current limitations include intermediate variability, vague tumor boundaries, and limited use of volumetrics. And so these guidelines would significantly benefit from more clear imaging definition for tumor subregions, standardized multiparametric protocols that allow for volumetrics and reproducibility, and also to allow more consistently across the sites and for clinical trials. Our lab is focused in pediatric brain tumors. Our lab is located at CHOP, and over the years, we have done some work over various tools that could help us for tumor segmentation, the identification, defacing of these patients, and also challenges that are associated with these tumor segmentations and how to address them, and also risk assessment in pediatric low-grade gliomas. If you're interested, these are some of the resources, and all of the codes are publicly available for use and research purposes. So I'm going to shift gears here and talk about PET-guided response assessment in the last 10 minutes or so. So why do we need PET-based response criteria? The main reason is that MRI, at the end of the day, it's a structural imaging. It has limited specificity in terms of giving us information about the tumor extent and also differentiation of progression from pseudoprogression. So we need a biologically relevant and quantifiable imaging endpoints. And PET actually offers that by giving us metabolic insights into tumor viability, and potentially offers us early and more accurate assessment of the tumor burden. The most commonly used PET agent in oncology, as probably you all know, is FDG PET imaging. It's widely available at relatively low cost. The problem with that is normal brain has high physiological avidity in gray matter, and that really decreases the usefulness of PET, FDG PET imaging in the brain. This is 3 examples from my colleague Diana Ivanitsa at Cornell that shows 3 patients with tumor progression, radiation necrosis, and mixed tumor progression, radiation necrosis. So PET imaging can be helpful, but it also has significant limitations. And that's when where amino acid imaging comes in. So amino acid PET imaging is helpful because amino acids play an important role in many cancers, including brain tumors, by contributing to cell growth and also mediating cell signaling, which causes tumor growth and survival. These are the 2 main transporters that are important in amino acid PET imaging, LAT1 and ASCT2. And amino acid PET imaging agents come in multiple flavors. C11-methionine is a methionine analog. F18-FET is a tyrosine analog. Flucyclovine is a L-leucine analog, and F-DOPA is a phenylalanine analog. FET, there has been extensive literature from Europe, and now we're using FET in US under an expanded access program. Flucyclovine is FDA approved for prostate cancer, and that's why it can be used off-label in GBM, and it's available. However, it's not FDA approved for brain tumors. The beauty of amino acid PET imaging is that it doesn't require blood-brain barrier disruption. This is an animal study that uses 5 different cell lines of glioma. And you can see that some tumors are enhancing. This is T1 pre, this is T1 post, so enhancing tumors at the bottom rows. And you can see PET uptake. However, in these 2 examples of non-enhancing tumors, pre and post, you can still see significant radiotracer uptake on PET imaging. So these tracers, they don't require blood-brain barrier disruption. And so that's why they have been very helpful in both primary and secondary brain tumors. So PET RANO criteria are a standardized set of response criteria using amino acid PET imaging. They're designed to complement, not replace MR-based guidelines. At this point, they are mainly expert opinion guidelines. And we need systematic prospective studies to validate them and to refine these guidelines to inform future updates. They apply to 18F-FET, C11-methionine, F-DOPA, and flucyclovine tracers. If you want to do PET imaging, it is very, very important to follow the guidelines that are published through the EANM, SNMMI, and EHANA RANO practice guidelines. This is the guideline for gliomas, and this is the guideline for brain metastasis. And initial and follow-up imaging with PET should be performed, preferably with the same scanner and protocol using these guidelines. Also, if we use one amino acid imaging, we need to follow up with that. We shouldn't switch amino acid imaging agents during longitudinal assessment. So this is the PET RANO 1.0 that was published last year for diffuse glioma. It uses static PET parameters of TBR max, TBR mean, and PET volume to assess response. It is applicable to both high-grade and low-grade gliomas. So definition of PET positive disease is defined as the volume of disease that is above 1.4, 1.6 mean brain background. So to assess the mean background, we need to draw an ROI, a crescent-shaped ROI on the contralateral brain. And then the tumor component that is more than 1.6 would be considered PET positive disease. And for definition of measurable and non-measurable disease, if we don't see any uptake, then there is no measurable disease. If we see some uptake, but the uptake is either less than 1.6 contralateral normal brain, or the uptake is less than half a cc, then that would be considered non-measurable disease. And if the uptake is both more than 1.6 contralateral brain and more than half a cc, then that would be considered measurable disease. In terms of target lesions and baseline imaging, the lesions with the highest uptake and largest PET positive volume should be looked at target lesion. This is kind of similar concept to RANO. And if you have multiple lesions, at least 2 lesions and not more than 3 would be considered as target lesions. Timing of imaging for newly diagnosed gliomas, we need to image 14 days before the start of any treatment. If the patient had surgical intervention, we need to wait 4 to 6 weeks after surgery. And it's very important because surgery and post-surgical changes, including hemorrhage or ischemia or inflammation in the surgical bed, could cause some false positives on PET. So wait 4 to 6 weeks after surgery. And for recurrent glioma, imaging needs to be done within 14 weeks before the start of any new treatment. Okay, for measurable disease, there are 4 scenarios. So if you have measurable disease at the baseline, we could either have progressive disease if we have enlargement of the measurable disease or presence of a new target lesion. Stable disease, if nothing changes significantly. We can have a partial response if the lesion responds, but we still can see it, and complete response if we don't see any metabolic activity. If the baseline PET shows no measurable or non-measurable disease, like this one, it's a no measurable disease, we don't see any activity, then there are only 2 scenarios possible. One is progressive disease, and one is stable disease. If we have a target lesion or a measurable lesion after no measurable or non-measurable disease, that would be progressive disease. This is summary of the PET RANO response criteria for progressive disease, stable, partial response, and complete response. And you can view the thresholds: 30% for TBR max, 10% for TBR mean, and 40% increase for PET volume of the lesion. So PET RANO brain mets 1.0, this actually published just a few weeks ago. This is tailored to challenges of MRI in post-treatment metastasis, follows a similar structure as glioma PET RANO. For meds, because there are usually multiple lesions, a maximum of 5 lesions could be included as target lesions, similar to PET RANO 1.0 for glioma. The PET baseline PET should be performed within 2 weeks before initiation of any therapeutic intervention. PET RANO for brain mets uses the same thresholds as PET RANO for glioma: 30% for TBR max, 10% for TBR mean, and 40% for PET volume. This is an example of a patient, a baseline imaging before treatment, follow-up imaging after 7 weeks. You can see on MRI, there is not much significant change. However, on PET imaging, there is significant decrease in TBR max, TBR mean, and PET volume, indicating a partial response. More and more investigators are just studying PET RANO criteria. This is a study that just came out a few months ago on 125 patients with IDH wild-type GBMs that had both FET, PET, and MRI. And PET RANO showed a stronger reader agreement and also identified more measurable lesions compared to MRI. RANO criteria, 90% of the patients had measurable lesions compared to 45% per MRI. This is a few examples that this patient, there is no measurable disease on MRI or PET. This patient on the middle, MRI didn't show any lesion, but PET showed a non-measurable lesion. And on the right side, you can see a patient that MRI showed non-measurable disease, but PET showed clearly a measurable disease. So again, discrepancy between MRI and PET, and much more measurable disease on PET compared to MRI. And again, also in terms of the spatial concordance, you can see a match here, a lesion that is both measurable and target on MRI and PET. A partial match, a lesion that is much smaller on MRI compared to PET. And a discordant lesion, a lesion that we can see in the medial aspect of the resection cavity on MRI, however on PET imaging, there is increased uptake on even on the lateral aspect. So we can see that PET not only can show more lesions, but also can show lesions that we even don't see on MRI. So in terms of regulatory perspective and the path forward, we need prospective validations to happen at two levels. We need studies to prospectively compare the newly introduced PET criteria compared to the RANO criteria. And also we need to show the surrogacy of these PET-RANO criteria for clinical endpoints. And these endpoints could be progression-free survival and objective response rate. I'm gonna move from these two slides. Just few slides about meningioma. So meningioma is also something that we use PET imaging for because they show somatostatin receptor transporters. So more and more patients are being imaged with gallium dotatate compounds. And these are the indications for imaging patients with gallium PET. In the context of tumor response assessment, this is a study that was published last year from my colleague, Dr. Ali Nabavizadeh at Cornell, that what her group showed that patients who have decrease in SUV or normalized SUV compared to supersagittal sinus after radiosurgery, they have basically a better progression-free survival and better outcomes compared to patients who didn't show decrease. And this is actually very promising for response assessment for meningioma. So at this point, we don't have a PET-RANO meningioma response, but I'm hoping that based on this study and similar studies that will come up in the next few years, we'll have PET-RANO meningioma criteria soon. And this is the figure from the same study that you can see parafolcian meningioma. Before and after radiation, no significant change on MRI. However, you can see clearly significant decrease in SUV of the lesion after treatment. And this shows the decrease on SUV and SUV normalized to supersagittal sinus, while MRI was relatively stable. So in conclusion, MRI remains foundational for response assessment, but has significant limitations, especially in non-enhancing and post-treatment settings. RANO 2.0 had critical updates in terms of standardization of baseline, allowing for 3D measurements and unified criteria for both high enhancing and non-enhancing gliomas. RAPNO is focused on pediatric tumors and address unique challenges that we encounter in pediatric population. PET-RANO criteria, they came out recently in 2024 and 2025. They offer biologically driven endpoints for glioma and brain metastasis. And future studies should be focused on validation of the response criteria, more and more harmonization of imaging and integration of imaging with molecular and clinical data. I'd like to thank my colleagues and lab members, and also the funding agencies who really have helped us doing research. And I want to thank you for your attention. Happy to take any questions.
Thank you for your excellent presentation. We have a few questions so far. And first is on mixed lesions. If the enhancing lesion is inside the filial lesion, should we add the enhancing and non-enhancing parts even if they are both parts of the same lesion?
It's a great question, and the answer is yes. In tumors that have enhancing and non-enhancing components, almost always the enhancing component would be part of the non-enhancing tumor, but they have to be measured separately and both be considered in response assessment.
Yeah, and the second is, do you think current imaging response criteria like RANO adequately address the challenges posed by non-enhancing tumor components, as you mentioned in your presentation?
Yes, I think they partially do. So I think that RANO 2.0 integrated the both contrast enhancing and non-contrast enhancing tumor. However, the problem with non-contrast enhancing tumor is that a lot of times it is not well defined. Sometimes it could be very ill-defined and kind of merges into the normal brain. So kind of defining where the border is could be very difficult. Also, post-treatment, the overlap between the post-radiation changes and what is the tumor is, sometimes it's difficult. So I would say that these are existing challenges. PET imaging could be helpful because we know that PET imaging frequently can show tumor that is outside the non-enhancing tumor component because it crosses the blood-brain barrier. However, that's not always the case. I've certainly seen many low-grade tumors. About 20 to 30% of low-grade tumors do not show radiotracer uptake on PET. In other words, they are PET negative. So I think this is certainly a challenge, and that's where we need more powerful technologies and continued research to continue to improve in the non-enhancing tumor component evaluation.
And this a question about PET. How do you see the development of new PET radio tracers targeting specific mutations in pediatric brain tumors?
Can you repeat the question, please?
How do you see the development of new PET radio tracers targeting specific mutations in pediatric brain tumors?
Okay, I guess what I understand from the question is that if patients with different mutations are being treated with targeted treatment, how do we use imaging, PET imaging to monitor these lesions? If that is the question, I think that depending on the tumor grade, whether that is high grade or low grade, and if the baseline imaging shows that the tumor is positive on PET, then serial PET imaging with amino acid could be helpful to assess the treatment response in these patients. I think there could be some indications for PET imaging focused on specific treatment. For example, if patients being treated with a targeted cell-based therapy, such as CAR T-cell treatment, there are some PET imaging technologies that have a PET reporter gene that basically can show the specific targeting of the tumor target that is being basically treated with the CAR T-cell treatment and so on. These agents are still experimental and not in clinic, but I do see that in future they could be part of the clinical trials.
Yeah, the other question is, in international multicenter trials or datasets, how do you deal with differences in imaging protocols when assessing tumor response?
That is problematic. So I would say that different consortia approach it differently. We can mandate some core imaging sequences. For example, the T1 pre and post, T2 FLAIR. These are the core basic sequences that would be required for response assessment. And based on the specific histology, there would be some sequences that would be required. So I think that for multi-center studies, as a part of the imaging protocol, the essential sequences should be specified and mandated. And some sequences also would be considered preferred or recommended. So based on the tumor that we're targeting, the appropriate imaging should be done.
And the other is about immunotherapy agents. Do you routinely take into account the specific therapeutic agents the patient is receiving, and do you interpret brain MR findings accordingly?
Yeah, I think that's something that is considered as part of RANO 2.0, that if the patient is within 12 weeks of radiation or any agent such as immunotherapy that can cause pseudoprogression, then we need to have a repeat imaging after 4 weeks before confirming tumor progression. So with MR, a 4-week follow-up MRI would be recommended. That's what we do to make sure that we take into account the possible pseudoprogression after immunotherapy.
I have a quick question.
Sure.
For spine imaging, do you recommend sagittal phaestosis with contrast or not?
So this is something that is recommended as part of the RAPNO criteria for leptomeningeal seeding tumors. So that's part of the guideline, and if you want to go by the guidelines, that's recommended. But this is not uniformly practiced across different centers because it's kind of resource intensive to do sagittal cysts or space on top of the other routine sequences. So this is something that's part of the guidelines, but we see significant variability in terms of centers doing it or not.
Yeah, do we take it with contrast or no?
No, that would be
Without contrast.
But post-contrast, you need the T1 based sequences post-contrast. But the Fiesta or CIS, they would be without contrast.
Do you think AI will enable more personalized post-treatment evaluation in the near future? Because we all have tumor boards, and sometimes I often wonder if we are really selecting the best treatment for each patient, especially for the pediatric patients.
Yes, I mean, this is something that our lab focuses a significant amount of time and resources on that. I kind of highlighted a few papers. We have done some work in low-grade gliomas, and yes, AI can do risk stratification and also can highlight some of the biological underpinning of these tumors. But really, the $1 million question is that when AI can really enter the clinic and tumor boards. I think that would take some time to make sure that we do prospective studies to show the added value of the AI models and to show that they're accurate and reproducible on independent data sets and prospectively. But by adhering that, it's just a matter of time. I think that the science just moves forward, and I definitely can see that in future AI would be part of what helps us to make decisions in tumors.
Do we have time, Bhavya, for other questions? Or
yes, we can go ahead with other questions as well, Dr. Ali.
Okay. And the other question is for RAPNO. Do you use axial or sagittal post-contrast or T2 weighted imaging for spinal target lesion measurement?
So the lesion should be measured in any plane that shows the lesion best. Yeah. Doesn't matter whether that's axial or sagittal. That would include both brain and spinal.
Okay, and the other is there any role for perfusion, DSG, ACL in response?
There is a role, but they are not part of the RANO or RAPNO guidelines, but we use them in the clinic. Sometimes they're helpful. So we use them in clinical practice, but they are not part of the RANO or RAPNO guidelines for clinical trials yet.
Yeah, and a question from Ghana classroom. In your experience, how often do conventional imaging findings like pseudoprogression or pseudo-response mislead treatment decision in glioblastoma patients?
I would say not uncommonly, and that's why we need more advanced techniques such as perfusion MR and also molecular imaging with amino acid PET, because conventional MRI can be frequently misleading. So there are two-way approaches. One is to do a 4-week follow-up to see how the lesion is going to behave, whether we're going to see continued growth or not, or using advanced MRI and PET.
Okay. So I don't see any other question.
Yeah.
So, yeah, we can close the session. And thank you all for joining us today from around the world. It has been a true pleasure to moderate this grant round. We are especially grateful to Dr. Ali Nabavizadeh for generously sharing his expertise and insights, especially so early in the morning from Philadelphia. And of course, thank you to each of you for your participation and questions. Stay curious and keep learning wherever you are in the world. Thank you.
I
Bye.
agree with Dr. Ellis. Thank you so much. Thank you so much, Dr. Ali, for such an
Thank
insight.
you. It was my pleasure.
And also, I think we
Yes.
also have Dr. Bhavya Rahani here, who is the founder.
Thanks so much, Dr. Ali. I was listening to your talk. Very excellent, very impressive. I'm a neuroradiologist too, so I think this
Of
was
course, yeah. Nice having you
personal.
here. Thank you for joining. It was really great to present, and I really enjoyed interacting with the audience and the question.
Excellent. Thank you so much. Very impressive talk. And thank you, Yelis, for such a good job moderating.
Thank you.
You did a great job. And thank you, everyone, for joining. Great questions. Very nice session. Everyone have a great day. Thank you.